Hi, welcome to this short video where we're going to look at just a few bits of cardiac physiology related to the blood pressure, how you take blood pressures, and what we can do with those numbers. So let's get started. First, understanding a concept known as a cardiac cycle. And that basically is from the beginning of one heart contraction to the end of that heartbeat. And in that amount of time, all four chambers are alternating between contracting and relaxing. So we'll have the two atria contract, the two atria relax. The ventricles will do the same thing. So both the right and the left side for the atrium will be contracting and relaxing together. And the two ventricles, the right and the left, will be contracting and relaxing together. And it does not go atrium contract, atria relax, then ventricles contract and ventricles relax. You'll learn the details of this in lecture, but for right now, I just need you to understand we are contracting and relaxing. And we have a word for that contraction. When a chamber of the heart is contracting, we call that systole. So we have atrial systole and ventricular systole. In atrial systole, blood that is in the atrium will be dumped into the ventricles. But in ventricular systole, that's when blood actually exits the heart. So from the right side, it will go to the lungs, and from the left side, this is how we are sending blood into the aorta to perfuse our entire body. And so it's during ventricular systole that we're going to be generating the pressures in those arteries that we're going to be measuring by doing our blood pressure. Now, when the chamber is not contracting, it is relaxing, and that is known as diastole. So practice saying these two words, systole and diastole. Okay. So ventricular systole, blood is going to be entering the pulmonary trunk, the pulmonary arteries, as well as the aorta and the branches from there. Ventricular diastole, no blood exits the heart. And so when the ventricles are relaxed, this is when atrial systole can occur, so that blood enters the ventricles from the atria. All right. So to measure blood pressure, first we have to know what pressure means. And so I'm sure you're well aware of this concept because you've learned it ever since you were a child and you took a hose and you sprayed it at somebody. We know that pressure relates to a certain amount of force that's being exerted. And there's things that we could do to change the pressure. For instance, you could turn the faucet on high versus low where it's just a trickle, or you could partially occlude it with your thumb, which makes it spurt and hurt your sibling harder when it sprays on them. That's the sort of stuff we'll discuss in lecture. I just want you to realize that we're measuring pressure, and the way we measure pressure when we're doing it for our blood pressure is in millimeters of mercury. And so you can see that on all your old school blood pressure cuffs at the doctor's office, where you can see the mercury on the wall, and you can see it rise and fall as they are taking your blood pressure. So the way we take blood pressure is with a machine known as a sphygmomanometer. Okay. And so the traditional sphygmomanometers are the ones that you see on the left where there is a dial. We're not using the mercury on the wall anymore. We have changed that to talk about air calibration to this dial. And the dial is kept over the blood pressure cuff area, so it's in the right part of the body. And then you have a little squeeze bulb and a little dial so that you can close it to prevent air from coming out, or open it slightly so air comes out slowly. So after you have pumped it up, all of a sudden the air isn't whooshing out, but it's coming out slowly, so you actually can listen for the sounds of the blood flow in the artery. Now, what you guys are going to be using are the electronic ones, where there's a built-in Doppler system and they are listening for those sounds instead of you having to have a stethoscope placed over the artery. So all the work's being done for you, so there should not be any fudging of numbers. You're going to use the numbers exactly as they are reported by your machine. So once you are done with this video, please put your cuff on, your sphygmomanometer on, follow the directions on the slides that are coming up. Practice taking your blood pressure several times the proper way and look at the variance in it. And then also make sure you can recall all these numbers off of your machine, because we're going to be doing multiple numbers before we ask you to take any of those numbers and write them down. Because in the writing of them down, you are doing activity which will change the subsequent values. So it makes the entire experiment invalid. All right, so how do you take a blood pressure? Well, traditionally, when you go to your doctor's office, they have you sit down, and before they do the blood pressure, they chat with you, because basically they're killing time. So they'll chat with you, ask a few couple of questions, stick the thermometer under your tongue. Well, then of course you can't answer questions then. Put the cuff on, and after you've been sitting there for a couple of minutes, they will take your blood pressure. Now, the most important thing is to make sure the correct cuff size is on you. If you are a tiny little thing, about the size, of a child, you are 90 pounds soaking wet and 5 feet tall, a normal adult cuff is too large for you. You actually will probably get much more accurate readings with a children's large cuff. Children's cuffs come in many sizes, as you can imagine. On the other hand, if you are a Rams football player, a normal adult cuff will give you artificially elevated levels, even if it fits around your incredible toned upper arm. So you need a large adult cuff. And so you can measure your arm size and see if the cuff you have is the right size for you. So the first thing you need to do is put it midway between your shoulder and your elbow, which usually means for an adult, the lower part of the cuff is about 1 inch above the crease in your antecubital space. Inside the cuff itself, you can feel where there is an air bladder that's going to be blown up. That must cover your brachial artery. So where is your brachial artery? Find your antecubital crease, go proximal to it. You can usually feel the tendon for your biceps brachii muscle, and it's just medial to that. If you put your fingers right there where I have them on my arm, you should be able to palpate your brachial pulse. Notice I am not trying to do it down here in the crease, because that's not where we are going to be taking our blood pressure. Now, if you were using the old school blood pressure cuff, where you palpated it that is where you're going to need to put the belt of the stethoscope so that you can hear the sounds. All right, so no matter how you do it, once you have the bladder placed there, you need to make sure when you wrap it around that the tubing is going to be falling distally over the front of your arm. I've seen many students where the tubing comes out the top and they don't understand why that's not an accurate measurement. And the last thing is to make sure you wrap it and you have that Velcro made so that the cuff is evenly tight around your arm. Not super tight, but it's evenly tight, and you can feel that if you moved your arm, it would not slide down on your arm. Okay. Now you're ready to start taking the blood pressure. And the first thing you need to make sure you do is that the arm is at heart level. Okay, so when your arm is here, yes, it's at heart level, or you can put it elevated on some books on the table. And the most important for you guys is that the gauge must be kept at heart level. So no, you can't hold the gauge up here. You can't have your arm at heart level and put the gauge down on a table that's a foot lower. So you need to hold the gauge at heart level, not above it, not below it, because otherwise it's not measuring what is accurate. So once again, accurate blood pressure readings, and I'm going to read this sentence too, it can only be obtained at heart level in your chest, and that's because of the hydrostatic pressure differences when the device you are using is either above or below. So the next concept, and notice we haven't started taking it yet, is do not move. Now, students often interpret this to mean, well, okay, so I shouldn't be running while I'm doing it. And so like they'll take one blood pressure right after the exercise, and then they want to start pacing around to decrease their activity, to do a cool down. You cannot do that. Do not move your body. Do not move your arm. Keep your arm in the proper position. Don't have it here and then put it back down and then bring it back up and put it back down and then put it up here to cool your armpit. Just keep everything in the correct position. So what gives you errors in measurements? Well, either the machine, because it's automated, will tell you have errors, or else it will give you a measurement which doesn't fit because it's an error. You moved, you have the wrong size cuff, you wrapped it wrong, you placed it in the wrong place, you inflated it too slowly on the automated ones. Make sure you've got fresh batteries, or you deflated it and you really didn't wait long enough for after it was deflated for your venous return to go back up before you re-inflated it. Okay, and then with the other ones, you're not, like, you've got to give it a chance to completely deflate on your arm before you inflate it again. So how does this work to give us our number? Well, normally we have blood flow that goes through our artery. It's beautiful laminar flow, and we can feel that in our pulses. When you put the blood pressure cuff on and you are inflating it, you need to inflate it about 30 millimeters higher than the systolic blood pressure. So what does that mean? If you know what your blood pressure normally runs, then you know how high it needs to be inflated. Now these cuffs will inflate higher, okay? What often happens is the first time the cuff may want to do your measurement twice, because the first time it's just trying to figure out where your systolic is, and then the second time it needs to make sure it's about 30 millimeters higher than that to make sure it's not missing your systolic blood pressure. In real life, if we weren't using automated machines, we do a palpable blood pressure if it's the first time we've seen somebody, so we have some idea where the systolic pressure might be. And then the second time we use the stethoscope, so we clearly are listening for the Korsakoff sounds, which have to do with flow throughout the artery. So once it is inflated, you would normally put your stethoscope over the brachial artery on the medial aspect of the arm. However, your automated machines have a sensor right there, and they are listening for, as the pressure goes down, that brachial artery, which was occluded, is now going to start opening up. And so they're listening for when the first sound occurs. This tells us when turbulent flow is starting to return to the brachial artery distal to the occlusion. And that's going to be our first number of our blood pressure, which is known as the systolic number, or the amount of pressure that was generated when the ventricles were contracting. Then you continue listening, and the quality of the sounds is going to change, and the last type of sound you're actually going to hear is very muted. And if you were listening with a stethoscope, you record the last number when you heard a muted sound. So you have to constantly be watching and listening and keeping track of those numbers, because you don't know when the last time is going to be, because obviously you're just going to have silence after that. So if you miss it, it means you need to start all over again. Lucky for you, on automated machines, they got it figured out for you. That last sound you hear is the diastolic pressure, because it's the last time where we have any generation of pressure while the ventricle is at rest. So what is blood pressure? So blood pressure basically is telling us what is the outward pressure of the blood against that blood vessel wall. And as I alluded to previously with the hose and the water, there are two major things that are going to affect the blood pressure. Number one, the amount of blood volume that is leaving the heart with the contraction. And the second thing has to do with resistance of the walls of the blood vessels. So the details of this we are not learning in this lab, but you will learn about them a lot in lecture material. So now that you have your two sounds, those two sounds for your blood pressure values are written as a fraction. And because the numerator is the first sound is a larger number. So the systolic blood pressure is always a higher number than the diastolic blood pressure. So here are the categories of blood pressure. Now, about a year ago, the numbers in the United States were changed slightly. However, some of the academies of medicine in the United States have gone back to the original categories because this is what the rest of the world and the World Health Association uses. So these are the numbers we're going to be using. A normal blood pressure in an adult, and realize that these values are only for adults. A normal blood pressure for an adult is a systolic blood pressure less than 120 and a diastolic pressure less than 180. So all those folks, including you perhaps, who have said the normal adult blood pressure is 120 over 80 is incorrect. It's less than 120 and less than 80. So if you look, both places clearly say less than. Now, a blood pressure that is systolic of 140 or higher is by definition high blood pressure, which is known as hypertension. So if I ever ask you what's high blood pressure, don't tell me hypertension. If I ask you what's hypertension, don't tell me high blood pressure. I'm asking you values, okay? So a 140 or higher systolic is by definition high blood pressure, or a 90 or higher diastolic is by definition high blood pressure. So those are the numbers you need to know for hypertension, 140 or higher or 90 or higher, which gives us this in-between range, 120 to 139 and 80 to 89. And this zone is known as pre-hypertension, which I'll talk about a little bit more in lecture. Now, yes, it's true that there are different severities of high blood pressure. And for instance, if you have a systolic blood pressure of 200, you need to be in the emergency room because you could have a stroke or a heart attack at any minute. It is that life-threatening. For this course, we do not need to know the different stages. They're just there for your information. Okay, so high blood pressure, 140 or higher systolic, or 90 or higher diastolic. So what's the problem with having high blood pressure? Well, the heart has to work harder to pump the blood. And this is a cross section, a transverse section of the heart. And on your right, that is the right atrium, the right ventricle, and on your left, that is the left ventricle. Now, it's normal for the left ventricle to be thicker than the right ventricle, but only about 2 to 3 times. And as you clearly can see, this left ventricular muscle is huge. It has hypertrophy so much because it needs to generate so much oomph to try to generate blood flow in your body. And as a result, look how small that chamber is. It cannot accommodate the normal amount of blood. So what are some risks? Who gets high blood pressure? Well, we always used to say by the time you were 60, you had about a 60% chance of having high blood pressure. And so we didn't really worry about it so much until you were in your 40s and 50s. And then we would start measuring it and treat you. The thing about high blood pressure, it doesn't cause any symptoms for at least a dozen years while it's creating a lot of damage to your brain, to your small blood vessels, for instance, in your eyes and in your kidney, damage to your heart, major damage to your kidneys, okay, with no symptoms. And so people say, well, I feel fine, so I don't want to waste my money on medication. It behooves you to do that. Now, the reason why we focus so much on high blood pressure in college nowadays is that due to the changes In the American lifestyle, both in diet and exercise, we know that at least 10% of college-age students in the United States have high blood pressure. And of those, at least 90% are undiagnosed. So when you're doing these activities, if you find that you have high blood pressure, please get pre-screened by a healthcare provider before you come into lab to do the exercising component, which will automatically be raising your blood pressure. Make sure your healthcare provider says it's okay for you to exercise. And if you do find you have high blood pressure, follow the guidance of your healthcare provider. So there are a lot of risk factors for high blood pressure. I'm not asking you to memorize these for labs. They're just there for your own edification, as well as a list of consequences. I will say for men, one thing that often catches their attention is the impotence, because the small blood vessels to the penis are affected just like the small blood vessels everywhere else in your body. All right, back to the lab topics. Pulse pressure. The pulse pressure is defined as the difference between the systolic blood pressure and the diastolic blood pressure. So in other words, if we are looking at the pressure wave that's generated during ventricular systole, we have a huge blood pressure generated. In this one, it's showing around 135, 137, and it's showing that falls way back down to probably around 90 during diastole. Okay, now notice, these are not blood pressures taking at the brachial artery. These are blood pressures generated in the heart itself, okay? So that's why these numbers are different. So in order to do the pulse pressure, we just need to do the math. What is the difference between these two? So systolic blood pressure minus diastolic blood pressure. That's what the SBD and the DBDD, and pulse pressure, PP. So I've just written them down as an abbreviation for you, realizing, of course, for all quizzes and tests, you cannot write abbreviations and earn credit. You must do the words, unless the directions say you can do it in abbreviations. So this represents the force that the heart must generate, or the heart is generating every time it's contracting. So that's one set of data we're going to look at, and we'll see how that changes at rest versus exercise. The second thing regarding your pulse pressure is not always the same. Sometimes we have a wider pulse pressure, and that could be because either if this is the difference, that difference can get bigger because this goes up, or if this stays the same, if this goes down. Do you see how that space gets different? Now, sometimes it gets smaller if this, the systolic, goes down, or if the diastolic goes up. So you can have wider pulse pressures or narrower pulse pressures. And in lecture, we'll talk a little bit more about this as well. So that brings us to our second concept related to cardiac physiology, and that is something known as the mean arterial pressure. So the systolic blood pressure is just telling us here's the maximum force that's coming. But when you think about the heart, if you've ever put your head on somebody's chest and you've heard that lub-dub pause, what you will realize if you think about it, do some critical thinking, is the heart spending more time contracting or relaxing? And you would say, well, lub-dub pause means it's spending more time relaxing, okay? And so we don't want to just rely on the systolic blood pressure. We rely on what is known as the mean arterial blood pressure, because this gives us the average pressure of blood throughout the entire length of the cardiac cycle. So it's a much better, in fact, it is the best indicator for what kind of tissue perfusion is happening. Neither systolic nor diastolic give us that information. So how do we calculate mean arterial pressure? Well, since the heart spends twice as amount of time in diastole than it does in systole, for the mean arterial pressure, we take the systolic blood pressure, value, we take a third of it. And we take 2/3 of the value of the diastolic blood pressure. So what does that look like as a math equation? Systolic blood pressure plus 2 times the diastolic blood pressure, add those numbers together, divide by 3. Okay, it's usually much easier to do the adding and dividing by 3 because usually none of these numbers divide evenly by 3, which means then you'd be working with odd numbers because 100 divided by 3 is 33.33, and then you're having to add fractions and stuff. So just multiply the diastolic by 2, add it to the systolic blood pressure, take that entire number and divide it by 3. So now you're going, but wait a minute, we did that pulse pressure calculation. Yes, knowing that the pulse pressure is the systolic minus the diastolic, we can plug that into here and realize for the mean arterial pressure, we can just take the diastolic blood pressure and add 1/3 of the pulse pressure. So know both of these equations when we come back into lab. And with that, we are done, and I will see you shortly. Thank you so much.